So good morning and good afternoon to all of you that have joined us. A very warm welcome on behalf of the IPB events team to today's Advocacy to Action event, Universal Health Coverage, Rethinking Prioritization of Eye Health Data for Advocacy to Achieve UHC by 2030. I'm now delighted to hand over to Simon Day to welcome you to today's meeting. Thank you very much, Simon, and over to you.
Welcome to all of our attendees. We're delighted to have you, and we are equally delighted that there's been much enthusiasm for this particular event. We've had 181 people register for this event, which is frankly an enormously successful amount, and Africa continues to lead the way when it comes to attendance at many of our IPB events. So we are enormously grateful for that, and we do absolutely hope to make this worth your while. Welcome to this Advocacy to Action. Advocacy Action is IPB's learning program for health advocates around the world. It covers global eye health updates, advocacy actions and approaches. It expands on resources, shares examples, and discusses priorities learnings at the global, regional, and national level. Following the 2021 program, this Africa event is the last of the 2022. And please know that all of the recordings of these sessions are available on the IPB website. We are grateful to our sponsors. Advocacy to Action 2022 has been supported by CBM, Lions Club International Foundation, Novartis, Roche, Saver, OneSight, and Operation Eyesight Universal. Please feel free to join the chat box. Let us know where you're joining from. Drop in a quick hello and keep commenting in the box as the session progresses. If you do have any questions, please pop them in the Q&A box, and we'll try and pick them up during the discussion and pitch them to our panelists. Also, we encourage you to participate in the Slido polls. We are very, very interested in your thoughts. This 90-minute session explores the prioritization of eye health data for advocacy to achieve universal health coverage by 2030. We'll be taking a regional look at what evidence can help our advocacy, how should we approach advocacy for addressing these gaps, how can global commitments and eye care targets, for example, effective coverage of refractive error or cataract surgery for 2030, help to frame our national policy dialogues and advocacy asks. Why is building the case for an SDG indicator on eye health, including health as part of Sustainable Development Goals, important? We as a sector need to identify and understand the priority areas of action that needs additional legwork to achieve universal health coverage within countries, and use global commitments, indicators, and frameworks to make and to argue the case. So we have an esteemed panel, a very knowledgeable panel, which we've brought together to help us answer some of these questions. And as this is an interactive session, we also will be looking to you to help us answer some of these questions. Let me quickly introduce our speakers. We have joining us first, we have Dr. Erin Magava, who is the IPB Regional Chair for Sub-Saharan Africa. We have Ms. Patricia Martin-Weissner, who is Director of Advocacy Aid. We have Dr. Boateng Woyafe, who is a Technical Advisor for Operation Eyesight Universal. We have Dr. Tesfaye Adera, who is Senior Global Technical Lead for Eye Health in the EXA region for Sight Savers International. We have Dr. Pribo Barengo, a Medical Officer in the NCD department of the WHO Afro team. And we have Dr. Mwiti Makatimo, who is Head of External Affairs and Strategic Partnerships for programs in the East Africa cluster for Novartis Global Health. At this point, I'd like to hand over to our own Regional Chair for Africa, Dr. Erin Magava.
Okay. Thank you very much, Simon. for the introduction, and welcome everybody to this session, important session, which is going to lead us to developing ways of having eye health care in Africa, which is robust and which is geared to save our communities as we go forward. Let's have our presentation set up. Thank you very much. Next slide, please. We are looking at eye care. There's a lot it can contribute to the SDGs. If we look at starting from SDG 1, 2 to 3 as examples, we can see that there is a lot of contribution which eye care comes in with is to actually achieve these SDGs. Next slide, please. Now, today I'm going to zero in on SDG 3, particularly target 3.8 about universal health coverage. When we talk about universal coverage, we are looking at a situation where all people have got access to promotive, preventive, curative, and rehabilitative services which they need at any one point, and this they will be doing without exposure to hardship, particularly financial hardships due to payments, out-of-pocket payments. The health sector, when it comes to this, already has got a lot of unmet needs, which have not been addressed, which I'll come to later on. But more importantly, we have got interventions which we have, especially for cataract and refractive error, and these can be included in packages of intervention at country level to move the SDG agenda forward. Next slide, please. Now, when we're looking at blindness and visual impairment, the estimates of the problem is actually very huge. We've got 2.2 billion people who have got impairment, of which 1 billion have not had any care delivered to them, and this is a very big number considering the population on the planet. And to make things worse, 90% of these people in need live in low to medium income countries, and 90% of these impairments which they have either have been prevented or they can actually be treated. Now, eye conditions affect everybody, starting from birth right up to death. So a lot has to be done in between in a person's lifetime for somebody to enjoy good eye health. Now, everybody in their lifetime is going to be affected by an eye problem, and this necessitates a situation where those who can't afford do have access to our health care, so to speak, so that they are not left behind or they don't get unnecessary blind going forward. Can we have the next slide, please? Now, we are not starting from scratch because already a lot of work has gone into this aspect. There is United Nations resolutions around eye care, WHO resolutions, as well as tools which we can use to actually move the eye health agenda forward. And member states are signatories to these documents. So we can use this as advocacy tools to encourage ministries of health to add eye health onto the packages of health as they go forward in their health care provision to their communities and citizens. Now, what else do we need? So we need policy to change at country level. And this is very important because this actually drives the strategic direction which a country takes, which results in good implementation plans in a country going forward. For that, we need robust data on what exactly we are supposed to be doing. And for this, I will actually allude a bit more in the next few slides going forward. However, we have to make other considerations as we advocate for eye care to be put, into the packages of health which countries are providing towards universal health coverage. Because there are other competing health issues which we have to take into consideration. There is HIV/AIDS, TB, especially in the low to medium income countries. And these are going to be competing with the sector in terms of the resources which are available for care to the communities around us. The other issue which we've just experienced globally are the global health emergencies. And these have got the capacity of taking resources away from eye care in those emergencies so that, the care which we are doing is affected, in that particular way. Resources become scarce in the countries that we live in. Next slide, please. Now, as a sector, we have generated a lot of data, in the past decades. A lot of RAPs have been done and other studies in country. So this is the map showing which RAPs have been done. As you can see, if you look at the Africa region, there are gaps which still exist in terms of data being generated in some countries. And this is creating a situation where we have only got estimates when we are talking about the number of people who are affected in Africa because of these particular gaps. We can only extrapolate from what we have. So this is an area which needs to be addressed going forward so that we can talk to our governments, advocate properly using the data which is available to us. Next slide, please. Now, we also have to generate more data away from the traditional data which we've generated in the past. So operation research, comes in, into play in this regard. When we talk about operation research, we're looking at, ways of generating information which is going to help us understand complex issues around eye care provision or health provision and help us in making the correct decision when it comes to prioritizing particular diseases or programs in country going forward. What makes it good is that when we do this properly, the actual decisions we make are actually going to be informed by scientific data, and we can explain it to the policymakers and politicians so that the provision of funds for our purposes is given in a timely manner. There are different types of research which we can do in this regard around diagnosis and exploratory processes, field interventions, evaluations, as well as cost-effective studies which we use to encourage the Ministry of Finance to actually give us resources about on how to provide eye care going forward. Next slide, please. Now, when we look at the arena of operation research globally, it is said and clear to see that not much has been going on. 40% of the literature in Africa, of global literature, comes from very few countries in the low, medium income countries. And if you look at the map on Africa, Most of the studies have been done in South Africa, mainly. So the rest of the African region has not done much in terms of operational research to help us choosing which policies to follow as we go about our healthcare or health provision as a whole. Next slide, please. Now, if we do this in a timely manner, or if we produce the quality data which we are talking about today, what this will do in our arena is that we will be able to provide, the data is going to help us implement better, in our provinces or countries as we go forward. We are also going to be using effective methods which are available at our disposal. Now, there are other areas which we should not forget about, or diseases which do not have interventions at the moment which are cost-effective or efficacious. Now, in our research, we will be able to make sure that going forward, these diseases are also catered for. The economic impact of vision impairment is partly known. Now, with our research, we can better understand this situation so that our advocacy efforts are actually better and more efficient than we are doing now. And finally, we'll be able to generate more robust indicators which we're going to use to monitor and evaluate our activities around eye care as we go about our work. Next slide. I think this is the last slide. Thank you very much, everybody, for listening. Good afternoon. Back to you, Simon.
Thank you, Aaron, for that regional perspective on why we ought to be advocating for the inclusion of eye health in universal health coverage. I'd like to introduce now our first interactive piece of this particular of this session, and this is going to take place by way of a software called Slido, where we would like to ask you, our audience, just a series of 2 questions at this point, and we'll come back a little later. And this is an opportunity where you, our audience, get to feedback to us on particular elements of advocacy and the importance of data with regard to promoting the strengthening of eye health at the regional and at the national level. So could we load our first Slido question? Now, for those of you who've not used Slido before, what we ought to be seeing any minute now is a slide with a QR code. And this is where we would encourage you to take out your mobile devices, scan the QR code, and then that will link you on your mobile devices to a page where you can then respond to the question which we're putting out. How are we doing on the technical side with our slide?
Hi, Simon. So just to confirm, so the Slido is incorporated into the platform. Mm-hmm. So the Slido tab can be seen on the hop-in page next to where you've been chatting and putting in your questions. So next to Q&A, you should see a Slido option. And on Slido there is where you should see the first question already there and ready for you to put a response into. I would also share it, as you suggested, Simon, as a QR code if people wish to view it access it on their mobile devices. So I'll just bring that up for you now as well.
Thank you, Russell. Okay, so I'm not seeing that, but let me shoot with our first question. And our first question, if we're thinking that vision needs to be a national development priority and its inclusion across systems is crucial, from your perspective, our audience, tell us an example from your setting where eye health is included and integrated within the wider health and development plans and policies. This could be around school health programs, maternal and newborn programs, rural development programs, health promotion, etc. So if you could respond to that, I think we ought to start seeing your answers popping up in our slider. Indigenous health. Maternal and child health. So this is driving, of course, the Department of Transport. These are all areas where eye health ought to be integrated. We've all known that we've all focused very heavily on eye health, and we know eye health ought not to be treated as a vertical issue. It really needs to be integrated and included across all of government. So these indeed are programs which, when you look at on the face value, would not necessarily include eye health, but really it's very important that they do include eye health. Okay, thank you. I might move on to our next question. Contextual and the relevance of evidence, or the lack of it, in the policy development objective act as hooks for advocacy action. What is the most compelling evidence you've used in your setting to advocate for the inclusion of eye health in national plans? Really, what is that piece that has helped you move the discussion forward or achieve that advocacy goal that you've wanted? Has it been around projected population needs, unmet demand, burden on the economy? We're all there are different touch points that we can note. So it's interesting to know what is working out there in real world examples. Prevalence, we see that. Proven reduction of blindness to diabetes through DR screening, yes. Cataract surgical coverage, yes. Gaps in eye health outcomes between Indigenous and non-Indigenous population. The link with NCDs. Public health and safety. Good. So it seems that there's a broad spectrum of pieces that resonate, but I think the key really is that kind of once you find that particular touch point, that you need evidence around that, and you need to develop that evidence and curate it and then present it to make your argument. Thank you to our audience. I think we are capturing all of this, and so we will certainly make a note of it, because I think there are one or two pieces that perhaps aren't at the top of our agenda, and these are certainly things that we can consider. I'd like to move us on to our panel discussion at this point. And as I've mentioned, we have some fantastic panelists. So this particular session, and we've heard from Aaron around why we should be advocating for the inclusion of eye health. And here we'd like to discuss specifically using eye care targets to advocate for eye health in universal health coverage, and the inclusion of these targets in national plans. So we're going to move across to our panelists. Firstly, we have Dr. Mwiti Makatimo, who is from Novartis, he was unable to connect with us today, but he graciously provided us a video with his response. So we've posed him a question, and he has a video response which he will share with us now. So our video to Dr. Mwiti was, why should we discuss data and evidence in advocacy? Why is it urgent and important to reframe our advocacy for and with evidence? Could we run the video in response to that question?
For advocacy to be effective towards driving the intended change, it must be anchored on a foundation of robust data and sound evidence. And in order to paint the picture clearly as to why data and evidence are integral cornerstones of effective advocacy, it is important to consider some critical perspectives with focus on eye health. First, so as to convince policymakers and decision makers to push for the required policy actions as well as implementation decisions towards universal health coverage for eye health, we need by all means to build a solid case for eye health. And this solid case must be based on real-world evidence and data. And this real-world evidence and data needs to demonstrate the problem that exists at the moment, the magnitude of the problem, and its negative impact on society. And this will help us to then understand and help the policymakers and decision makers to understand exactly what is the problem that they should be addressing themselves to. And once these dimensions are understood in their eyes, then it would be easier for us to drive effective advocacy that will bring about the required change. And indeed, we must also take our evidence-based advocacy efforts beyond problem description and provide solutions, and solutions that are also based on evidence. And in addition to the solutions based on evidence, clearly paint the picture of what the roadmap will look like towards implementing those solutions. And additionally, what kind of impact we shall be able to achieve positively on society once those evidence-based solutions for eye health have been implemented. This is what will lessen the burden on the side of the policymakers, on the side of the decision makers, to then have the ease and the comfort to trust that should they go the way that we are advising them to go based on our advocacy efforts, then for sure, they will most likely be able to achieve the desired impact, the desired change, and transform society, and then give themselves a good opportunity towards driving policy and action that will enable achievement of eye health on matters universal health coverage. Therefore, in conclusion, it is important. It is important that we base our advocacy efforts for them to be effective on real-world evidence, on robust data, and this data ought to describe the problem or to clearly show what solutions exist and the roadmap to implementation of those solutions. And importantly, what impact these solutions derive for society. And through this, then we, of course, give the confidence to policymakers, to decision makers, to all stakeholders within the ecosystem to actually push and travel that road that we recommend, that is based on sound evidence, that is based on robust data. And by so doing, we shall for sure be able to have achieved effectively the transformation of matters eye health in the context of universal health coverage.
Our thanks to Dr. Mwiti Makatimo of Novartis. So he spoke of real-world evidence, and when it comes to evidence in particular, we know that there's been a World Health Assembly resolution passed with 2 new ambitious global eye care targets for 2030, which aim for an increase of 40% in effective refractive error coverage and a 30% increase in effective cataract surgery coverage. I'd like to pose my next question to Dr. Prebo Barango medical officer of the NCD department of WHO Afro. And why do you think advocating for these global commitments can influence policy action at a national level?
Yes, thank you very much, Simon, and it's and thanks to the organizers for this very, very important advocacy platform. I think that it's high time that we start raising the stakes on the importance of eye health. So yes, the advocating for the global commitments is very, very important to influence the policymakers at national level, because oftentimes when these global commitments are made, often there is a gap between the global commitments and implementation at the national level. And so it's important that we are able to bring these issues in piecemeals in ways that are relevant to the context, the country context, and be able to now make it easier for the policymakers at the national level to be able to understand the implications, both in terms of the magnitude of a problem, as well as possible and solutions to it. For example, for the UHC, it's important that the World Health Report in 2019 actually highlighted the importance of eye health in UHC as part of UHC. But to what extent have we been able to domesticate these recommendations in terms of service coverage, in terms of financial risk protection? You find out that most times at the country level, it's really not been taken up because there's not been any direct sustained effort at breaking down what it means in terms of the global commitment, how to domesticate it, how can we ensure that eye health are integrated into the UHC benefit package at the primary health care. How do we do that? Not just, so it's important that we generate advocacy events to break down the key components of this global commitment so that policymakers at the national level are able to digest and see the implications of implementation of this at their country. For example, the example Aaron gave in his opening slides was that approximately 2.2 billion people have visual impairments globally, and 1 billion people have, about 1 billion people have preventable, are blind from causes that are preventable. But as you can see, it's an estimate, and at the national level, it really doesn't strike any, it doesn't ring any alarm on what is happening at the national level. So it's important that we're able to use this global commitments and regional commitments and break it down at the national level for policymakers to be able to really see what the implications and the ramifications of what can be done, what the issues are and what can be done. Thank you.
Thank you, Prevo. Those are indeed key points, and certainly important to have those picked up at the national level. To our audience, I encourage you again, please, to just pop any questions you have for our panelists on this topic in the chat, and then we will put this to them. My next question is to Dr. Tesfaye Adera, Global Technical Lead for Sightsavers big one for eye health in the EXA region for Sight Savers International. Tesfaye, our question to you: what will be your top 2 tips when advocating for evidence for policy action?
Thank you, Simon. A lot has been said by the previous speakers, and I think this question is very important. What are the top 2 tips that I can give? The first would be that evidence talks. So we are living in a world which is very much clearer because of evidence. Evidence supports our ideas, our talks, our proposals, and we have to understand that evidence talks. It's much easier to come with evidence and approach national policymakers or other bodies who are actually deciding on policies as well as on allocating funds and resources. So we need to come up with a very clear evidence and present ourselves. So we need a robust evidence. A good example is what has been mentioned. About 1.1 billion people live with the consequence of sight loss because of lack of services. When we compare this with other diseases, for example, around 38.4 million people live with HIV. Now, 38.4 million when compared to 1.1 billion, this is clear. The weighing side is there is huge need for eye health. Let's look at malaria, which is another killing disease. We see that about 241 million people were affected by malaria in the last year, and out of those 627,000 people died because of malaria. So 241 million people with malaria compared with 1.1 billion people. Again, the weighing is on eye health, but on the malaria side, it's a killing disease. So the evidence is a little bit more weighing on to malaria. But we can see that if we present facts based on evidence to policymakers, it will be very clear that there is a huge need for eye health to improve. So this is one of my tips. The other one is phrasing when we approach policymakers, when we're advocating for policy action. We need to phrase it properly. So instead of just coming up and saying that there is a huge need or a huge gap for eye health services, we need to phrase it properly so that it is very clear and evidence showing that there is a huge gap, and the phrasing is the second part that I would give. So base it on evidence and phrase it properly, and that should push policymakers into in the right direction when it comes to eye health. Thank you, Simon.
Thank you, Tesfaye. I like your 2 tips. I like very much your phrase, evidence talks. And you make an excellent point when you talk about the burden of disease. And I think quite often it's just that policymakers they're not aware, for example, of the numbers, as you say, 1.1, the eye health figures versus the figures for HIV, for example. And I think that then speaks to your next tip, which is to articulate our argument, to make sure that those numbers don't just land as statistics, but they land with meaning, and they land in a way that get picked up by the policymakers, and they land in a way that resonates with them, and does then drive them to bring about change. Just so I thank you for your response there. I'd like to pitch my next question back to Dr. Barango of the WHO, because he and I have had lengthy conversations about universal health coverage. So, to Dr. Prebo, what does Africa need for universal health coverage? What would be your top 2 priorities for advocacy action?
Yes, Simon, thanks for that. So for Africa, what we need for UHC is, one, to be able to have eye health, because the key challenge with policymakers is that there are several competing issues that they have to deal with, but resources are limited. So they are more open to looking at solutions that would not take away resources, because as things stand, it's a zero-sum game. If you take away the national resources for health is fixed, taking away from one, giving one means taking away from the others. So what the first thing Africa needs is to ensure that eye health is part of the broader NCD agenda. One, because we know that in the African region, member states, ministers of health signed up to the Brazzaville Declaration, which on the importance of non-communicable diseases, and the ministers recognize that eye health is an important part of non-communicable disease. So what we need to, so the first thing would be to have eye health agenda within the broader NCD agenda. And we know that there are several entry points. We know, diabetic retinopathy, because of the increasing burden of diabetes, is a huge issue. We know, there are other health issues that are linked, that NCDs, other NCDs are linked with eye health. So that is one, linking eye health as part of the broader NCD agenda. The second one is in terms of ensuring that eye health is also, because at the service delivery level, a patient walks in, an eye does not walk in. So in terms of also managing eye health, because we have a limited human resource for eye health, we need to maximize the best based on what we have. And at the PHC level, we need to ensure that eye health is part of the WHO PEN package or other decentralized packages for treating patients, so that the service coverage index will improve, not just for NCDs, but eye health is carried along as part of this. So the two things is, one, eye health being part of the broader NCD agenda, generally, meaning that eye health is included in the NCD strategies and the national strategies and policies. Two, in terms of managing and treatment of eye health, prevention, early diagnosis, treatment, and rehabilitation for eye health is also integrated into the existing platforms at the PHC. That way, we maximize the use of existing resources. That is more palatable and that is easier than coming up with a vertical program for eye health, which will not be sustainable because of the resources that are currently available in the African region. Thank you.
Thank you, Prebo. Again, I think very important, and this speaks again to integration, the integration of eye health broadly across health systems, broadly across all systems, and elevating eye health within the NCDs and integrating eye health into primary healthcare. And these, I think these are, there's a robust argument for that, and that's something we ought to be doing. A question, if I may, back to Tesfaye, and this is a question from the audience. The audience has posed that, as Erin has showed, there is a lack of evidence in many countries across Africa. What is the best approach when there is little evidence in a country? So how can a country which may or may not be well resourced go about beginning to develop the evidence where it does not yet exist?
Thank you, Simon. I mean, the first thing should be to understand that there is lack of evidence and that there is a need to come up with evidence. So when you're planning on improving your eye health status in the or services in the country, then the first thing should be to think on how we can come up with the evidence. So to do a sort of situational analysis, or maybe to do an EXAT, which could base the ground, or which could give us a good base to step on to go to the next step. So evidence is important, but with a shortage of evidence, we need to plan on how to get evidence. And then the other possibility is to use existing evidence from neighboring countries, from the region, which may be similar to the situation that we are in, and base our advocacy and our planning based on the evidence that's existing. But we need to think that evidence is really, really critical, especially in this day and age when everything is being based on evidence. And when we come to medicine, other thematic areas like general medicine, surgery, gynecology, maternal health, everything is coming up with their own evidence and competing for the same resource. We need also to come up with evidence. So the best approach would be to look at whatever evidence that is there existing, to try to generate evidence, and then also use evidence that is in the region, in the area, to base our approach. Thanks, Simon.
Thank you, Tesfaye. I think that's very helpful. It's a good point to consider what neighboring countries or what is happening in your particular region to use as a starting point, and also that can be used. You can then align yourself, I guess, with regional level advocacy to begin that top-down approach while looking to develop your own evidence for your own national and bottom-up approach. Thank you. We've had a very interesting observation from Frederick as part of our audience, and I think this comes out of Prebo's commentary around NCDs, and what Frederick has said is, my observation is that the only health language that our politicians understand is NCDs, and the only risk they pay, and it's the only risk that they pay attention to. Why not make it clear that most eye conditions are NCDs, and most NCDs cause eye conditions, including blindness? Frederick, I think, thank you. That's a key point and a good takeaway that we all ought to consider when we're looking to arm ourselves with good advocacy messaging. So I'd like to, this will be the last question, and if I may, I'd like to just ask briefly for both Prebo and both Tesfaye to respond to this, just perhaps just briefly, but I'll ask Prebo to respond first, because I think this wraps up this session nicely and then leads us into our next session. And what suggestions would you have for approaching advocacy to include eye health in areas of government outside health, like in education, in the workplace, Department of Transport, where we've had little contact to date? Most of our discussion today has been around the integration of eye health within health, but we now have the understanding that we need to start looking beyond health at other departments, other ministries, to ensure that eye health is comprehensively integrated. So Prebo, could I come to you just for a brief response to that, and then Tesfaye afterwards?
Yes, thank you very much, Simon. And that's very, very important because it just highlights the key issues, not just with eye health, but with NCDs broadly. And one of the key challenges with NCDs, including eye health, is that it affects sectors a lot outside health. And so what what will be needed, what will be important is that if eye health is part of the broader NCD agenda, most countries, the recommendation is to have a multi-sectoral coordination mechanism. The multi-sectoral coordination mechanism will include key sectors that are outside the health sector, because we know that both NCDs and eye health are not necessarily just a health sector issue. So within that framework of the multi-sectoral coordination mechanism, where you have sectors like education, you have transportation, you have security, and you have other agriculture and other sectors. Within those, within that platform now, we can now start advocating for the importance of, for example, for transportation and road traffic in accidents. How many? What is the policy on ensuring that, you know, drivers have eye test, or ensuring that people that are not people that are visually impaired are not given this transfer, are not given the possibility of doing of transport. Those kind of issues can only be brought about within that broader structure. So it is important for eye health to be part of the NCD agenda, and we can now advocate for and bring up these key issues within the platform of the multi-sectoral coordination mechanism for NCDs. Thank you.
Thank you, Prebo. Tesfai, could we hear from you on the same point?
Thank you, Simon. I think the key point here is to look at the problem as not an eye problem, but as a person problem. So a person who has visual impairment is a whole person. And if you look at it that way, then all the other areas will be coming in nicely into the picture. For example, you go to a child who has a visual problem, he will have a problem with his education, and he will be maybe falling back in his results. And this will be mainly identified, followed, and treated by the education system rather than the health system, rather than the eye health system. Just like Prebo mentioned also, you take transportation, a lot of our transportation systems, be it cars, trucks, or planes, they require to have good eye health. You go to agriculture, the same thing. Good eye health is really key for people to go in the field produce. So almost all aspects of humanity needs to have good vision or good eyesight to function. And if we come back and look at the challenge again, it's not just an eye health problem, it's a people's problem, it's a community problem, and as such needs to be addressed in total through the community. And this needs approaching or advocating for all the sectors, be it transportation, be it education, be it agriculture, to have or to contribute towards good eye health for the community. So I think approaching it this way will make it even more clearer for the whole community, for the whole government to work to have better eyesight in the community. Thanks, Simon.
Thank you, Tesfai, and thank you, Prebo. To Dr. Mwiti, who joined us by video. I'd like to thank you as our panel for having participated and answered these questions, and for exposing yourselves to being put on the spot in front of our audience. I think you've come up with some very rich commentary on the subject, and something that our audience can certainly take away. And thanks to our audience for some keen observations and some interesting questions that came through as well. We're going to move on to our next Slido question, which if we can arrange it the same way that we did the last time round, Russell, where we can have the option of the, yes, thank you, where we can have the option of the QR code as well. And also if we can have that visual up as the responses come in. So our next question, as you can see there, to everyone, what tops your list of policy actions that is required to help achieve universal health coverage in your setting or country? Do you target getting eye health included in the health insurance scheme? Do you target integration into school eye health programs, maternal and newborn programs, rural development programs, health promotion, workforce systems? Which would you prioritize when you're approaching your policy actions to achieve universal eye health? I think this is an interesting subject because, again, here we're talking mainly about health programs, which is naturally our starting point. It's where we're comfortable, and it does still require a lot of work. But I think as we'll see in our next session, we also ought to start thinking more broadly. National eye strategy, including refractive error, indeed. Indeed, and that is the focus of policy dialogues. So we have spoken with, we've spoken on this in the past, and a key part of implementing integrated people-centered eye care is to undertake a systems assessment, but then to develop a national strategic eye health plan, and of course have the kind of have ministries commit to the implementation of that plan. Healthcare promotion. Marginalized populations are specifically included. Yes, I think governance and leadership, yes, indeed. Increased funding. Increased funding is vital, and of course, quite often when we invite or when we approach those to whom we're applying our advocacy, we speak with the decision makers, but often a challenge we face is we'll speak with the decision makers on health, and they may agree with what it is that we're going to say, but they then need to go to the finance people to have this budgeted and in order for it to be implemented, and that again can bring its challenges. So indeed, I think it's always important when advocating to kind of think to think of all of everybody who needs to be involved to have your policy not only adopted but implemented as well.
Universal health coverage, rethinking prioritization of eye health data for advocacy to achieve universal health coverage by 2030. We're going to look at the example from Ghana. Next slide. Universal eye health coverage has been sung since early 2000s, and in the year 2014-2019, an action plan was actually developed. The aim was to reduce avoidable blindness and visual impairment as a global public health problem, and to secure access for those who are visually impaired to be integrated into the society. Now, this actually had three objectives: generation of evidence on the magnitude and causes of visual impairment, development and implementation of integrated national eye health plans, and then multi-sectoral engagement and effective partnerships. These had three indicators, which were the prevalence and causes of visual impairment, the number of eye care personnel, and cataract surgery. Now, Ghana looked back and we saw that we had been using proxy figures. We're actually using the prevalence of 1%, which was from WHO. And along the line, I think somewhere in 2009, RAP was done in the Eastern region. We discovered that the prevalence was actually around 0.7%. In the year 2015, next slide, we conducted a national blindness and visual impairment study. And this was a population-based study. By the way, Ghana now has a population of about 30.2 million. Females are more than males. And the area, surface area of Ghana is 239,460 square kilometers, 16 administrative regions, and 216 districts. Now, about 6 of these 16 administrative regions do not have resident ophthalmologists. And we'll come back to this later on. Next slide, please. Ghana has a dedicated National Eye Care Secretariat or unit with a national coordinator paid by the government, and salaries of the majority of frontline eye care staff in public facilities are all paid by Ministry of Health. Information system exists with eye indicators included in the DIMS 2. And unfortunately, it focuses only on outputs, number of consultations, number of cataract surgeries done. There's little or no data on quality of service. Availability of national prevalence and major causes of blindness and visual impairment is there. And data from this survey is being used for advocacy with considerable outcomes. Success. Primary eye care is getting integrated within the primary healthcare system. And long-term support from national and international donors have existed. And gradually the international donors are pulling out, some are coming in. Almost every district hospital is staffed by at least an ophthalmic nurse, but inequitable distribution of human resource in eye health, the concentration of ophthalmologists and optometrists in the urban areas. National health insurance exists. It covers most diseases, including eye care, which helps to reduce financial barriers. There's good collaboration between national eye care units and international NGOs. Next slide, please. From the blindness and visual impairment study, we found out that the prevalence of blindness in Ghana as at 2015 was 0.74%. The confidence interval between 0.48% and 1%. And severe visual impairment was found in 1.0%. Confidence interval is 0.76% to 1.38%. The major causes of blindness were found to be cataract, glaucoma, corneal opacity, retinal diseases, and these were actually the major causes. It was very interesting to find out that visual impairment was quite significant, and the major causes of visual impairment was refractive errors and cataract-related issues. These account for over 80% of the blindness, of the visual impairment numbers. But interestingly, we found out that those with refractive errors, only 5% had eyeglasses that they were using. 95% had no eyeglasses. And that was quite an interesting revelation. We also found out that with the blindness, about 80% of the causes were avoidable. Only 20% were unavoidable. This was also very interesting. And we discovered that from the cataract blind, about 65% were females. And this struck everybody. Now, these are very, very interesting revelation, and it became a very, very important tool for advocacy in our country. Next slide, please. Now, when it comes to looking at indicators, this one example where we looked at the cataract surgery rate, the trend from 2015 all the way to 2020. Of course, the target is 2,000. To our surprise, like you saw, the numbers have been quite low all along. In 2019, and I'll explain what happened. Actually, as a result of the outcome of the Blackness and visual impairment study, the results showing that about 58% of the blind population are blind from cataracts alone. This again became an advocacy tool, and through that, the National Cataract Outreach Program was born. It took a couple of years to get our acts together, and that's where you see the spike in 2019 of 783. Unfortunately, COVID came, and in 2020, not much happened. But we are very, very confident that with the National Cataract Outreach Program in place, the cataract surgery rate is going to actually go up significantly. Next slide, please. Now, this is something that we all know, that to be effective, advocacy must be supported by high quality information. We usually obtain this through research. For example, research into the extent of eye health problem and the effect of the strategies that can overcome it. In the past, advocacy had been held back by the lack of such important information. At a more local level, research can establish the prevalence of the conditions and whether the necessary resources are available for the visually impaired people. Research can also create evaluation tools or questionnaires that can be used to measure the impact of visual impairment on people's lives. And as I'm talking right now, we just commissioned a study on the impact of cataract surgery, the economic impact of cataract surgery on the lives of the citizens. And this will be a 2-year study, longitudinal, that we're going to see and document and use the results for advocacy again. Talking about advocacy, when the results of the survey came out, and we discovered that only 5% of those who actually need eyeglasses have them, we use that again as an advocacy tool. And suddenly we had several organizations who were interested in providing affordable eyeglasses trooped into Ghana. I'm happy to note that this has been a positive impact. And we are looking at a time when we have the opportunity to actually do another survey to measure the impact of all these interventions on the eye health of the people of Ghana. Next slide, please. Now, when we looked at our numbers, like cataracts accounting for about 55% of the blind population in Ghana, yet the cataract surgery rate is so low. The National Cataract Outreach Program, whereby the Malaria Cataract Project and other NGOs are participating actively. Glaucoma, accounting for 19.4% of the blind population. Again, we used that as a tool to advocate with the government, the Ministry of Health, Ministry of Finance, and with the pharmaceutical companies. And I'm happy to report that the prices of some of the anti-glaucoma medication, which was out of reach of several people, were dropped to an affordable rate. Now, the fact that only 5% of people with refractive error, in fact, we converted that into real figures, and we came up with the need for about 7 million pairs of glasses for people who need eyeglasses. And with this tool, we managed to attract a number of organizations that have come into the country willing to provide affordable eyeglasses. Now, with the 2030 in sight, we think there's an opportunity here again. You see, there are 2 new targets that have been suggested. And just as we adhere to the previous ones suggested, to be well for countries if we come up with strategies to adhere to these. The targets address the 2 leading causes of blindness and visual impairment, cataract and refractive error. To address the huge unmet need in eye care, all countries have committed to 40 percentage point increase in the effective coverage of refractive errors by the year 2030. They've also committed to a 30 percentage point increase in the effective coverage of cataract surgery by 2030. Now, to my knowledge, very few countries, at least in our part of the world, have an idea of what the effective cataract coverage, cataract surgery coverage is in 2020, 2021, or 2022, let alone the effective coverage of refractive errors. So my question is, what will be our reference point to increase by 40% or by 30%? I've given a thought about this, and I would want to make a suggestion that we, as eye health advocates, have to spring into action right away. My recommendation is we all do some advocacy for support to conduct a baseline effective cataract surgical coverage and effective refractive error coverage. Once we have the baseline, in the year 2030 or 2029 or wherever, we can go back, measure, and then see whether we have increased it by 50% or by 12% or by whatever. But when you start talking about this, everybody starts talking about where is the funding going to come from. And I would like to share our experience on how we managed to get the cataract, the national, the Ghana Blindness and Visual Impairment study done. Budget was a problem, but 2-3 NGOs came together with some funding. Then we approached the Ministry of Health, who offered to release the technical staff, the ophthalmologists, the nurses, the optometrists, who will be going out to do the survey. We approached the Ghana Statistical Service, who has competent staff in statistics and epidemiology. So they also came on board. They calculated everything for us, the sample size, enumeration areas, the demographic data, everything for us. We got to the Ghana College of Physicians and Surgeons, the Faculty of Public Health, where the write-up and all those other things also came together. And I'm happy to report that we managed to undertake this survey, one, in record time, and two, at a very affordable price. So I would want to encourage each and every country to attempt to come up with a baseline right now. Then we continue with our interventions. And then around 2030, we go back and then do another survey, then measure to see where we are. With this, I would like to thank the organizers of this meeting for putting this together, because without any numbers, we cannot forecast anything, we cannot plan anything. Thank you for your attention.
We're going to move on to another area now, and here we're going to hear from Patricia Martin-Weissner, Director of Advocacy Aid, and we've been working with Patricia on a multi-sectoral systems review tool. And Patricia will indeed tell you more about this tool, but what I think is key as an introduction is that this tool is designed to present to us a policy landscape in a country of where eye health features and where it doesn't feature, not just within health, but across all of government. And this is something that our panelists were speaking to earlier, is that we need to start looking outside of simply health. We need to start looking at where it features in departments of education, departments of finance, departments of transport. So naturally, our key focus is health, but eye health ought to feature very broadly. So I'd like to hand over to Patricia now to showcase diagnostic data for an evidence-based system, which was something we also piloted in Kenya. So Patricia, over to you. Thank you.
Thank you very much, Simon, and to the organizers for giving me this opportunity to share some of my thoughts with you and some of the very rich work and experience that we have accumulated through the process of developing this multi-sectoral systems review diagnostic tool, which we've had the privilege to pilot with the team in Kenya. So what I'm going to share with you today is incredibly relevant to all that have been raised in all of the previous presentations and the panel discussion, linking up very closely with advocacy point of view in Africa specifically, for effective change to really move closer towards universal health coverage. And I'm hoping to share some of the fundamental underpinnings or rationale of this tool, grounded in what is required for successful advocacy in a context where there are competing demands, where there is this demand for integration. There are very common experiences of good policy development but poor implementation. But we've had a real struggle in moving on the continent from good policy to implementation. And often I think it ties up with two key themes that have come out through the discussion up until now. The first links to the fact that we are not necessarily grounding our advocacy in the sort of foundational pillars that make for effective advocacy, which is, yes, data on the one hand, but on the other hand, there has to be a legal responsibility. Advocacy depends on having a very strong legal ground, which elevates your ask over and above another ask. So over and above the differences in numbers, the strength of the legal foundation for your ask is absolutely critical. And then the second area, I think, where we've seen quite a challenge that has limited or perhaps diluted our advocacy is that our asks to resolve the challenges or to move us forward have not always been specific enough and in the language of systems developers who are responsible for integration and implementation. So it is in this context that I've had the privilege of working with IAPB on developing what we've called the National Multi-Sectoral Systems Review, which really is a tool to move advocacy to action in 2022 in Africa. So what we are really focusing on here in terms of the tool and one of these sort of the framing or the logic behind the tool is this tool is a mechanism for leveraging maximum advocacy value out of the fact that vision is a rights-based sustainable development imperative. The fact that vision is in fact elevated over and above other public health issues as a very direct issue that impacts on achievement of sustainable development as well as the rights of individuals is of incredibly important advocacy value. And we need to be leveraging that value in this context of competing demands and limited resources. So as I mentioned earlier on, I mean, just understanding where this value lies, we need to look back at what the two fundamental pillars of effective advocacy are. And that is, it has to be grounded in evidence. You have to have your data, not just on the scale of the problem, but the consequences of failing to address that problem for the country. I mean, linking it up with the consequences for sustainable development, for example. And then the second element of an effective advocacy demand or campaign is that it has to be grounded in legal responsibilities. When you ask for something, when you are asking for change, I mean, that is really what we are doing when we're dealing with advocacy. You know, the question we are going to be encountering is, well, why should we do this rather than something else? And you have to have a very strong legal justification for that, which is what will get you over the sort of the finish line as opposed to perhaps a competing request. And the fact that we have a global right to cite suite of instruments, the World Health Assembly resolutions, your right to cite, your various treaty obligations, together with development instruments. So we've got treaty and we've got development sight, or the prevention of blindness, as a right and a sustainable development imperative. All of our African countries have endorsed these treaties and which create a legal duty avoidable blindness through universal health care. The obligation created is a legal obligation. It is an obligation for which countries have to account to our treaty bodies, and that is to achieve universal health coverage for integrated, people-centered eye care. So the instruments, treaty instruments, your human rights instruments, and your development instruments create a very clearly defined legal obligation. So they spell out the targets. They spell out very ambitious targets most recently, but what's really the value add that we see here is that these instruments, when you unpack them carefully, they obligate implementation. They do not just set those targets, they create a very clear duty for the adoption of measures that will result in implementation to realize those targets. And then going in further, in a little bit closer, what these instruments do is they actually spell out in a lot of clear detail what the requirements are for implementation. And those requirements come together in one overarching requirement, and that is that eye health care must be delivered to provide universal, to be universally provided to prevent all forms of avoidable and treatable incidences of vision impairment or blindness through public, integrated, multi-sectoral eye health systems. That is the overarching implementation responsibility. However, when we look at these instruments, they provide a roadmap of prescribed measures that constitute the building blocks of that integrated eye care system. And these are mandatory. They are prescribed by these instruments. So we all know that the advocacy value of treaty and development instruments is that they create a suite of obligations. And the commitments that are made must then be domesticated through their integration, the integration of those commitments into policies, laws, and strategies, which mandate not just health, but also education, early childhood development, disability, and basic services. So that is the first and foremost responsibility, is that these commitments have to be domesticated through your legal framework in the form of your policies and your laws. However, policies alone or laws alone are not enough. They must be implemented, and they must be implemented through systematization. So what do we mean by that? What does implementation look like? Policy commitments must be actioned in the first instance through programs across health and your supporting sectoral systems, which then provide the services that are necessary to prevent and to treat vision and prevent blindness. Those programs must be in turn be supported by human resources, not just to deliver, but to plan and monitor impact. And those human resources have to be enough in number, spread, and qualifications. Thirdly, the programs must be supported by adequate infrastructure, both for planning and delivery. We know that without the necessary technology and infrastructure, the programs will simply never get off the ground. And all of this culminates in a requirement to ensure that your programs are costed and supported by adequate public financial resources that will ensure sustainability of delivery as well as coverage and quality. And that is the critically fundamental distinction when it comes to, for example, advocacy for universal health coverage of eye care services. Because it is a sustainable and a rights-based development imperative, those resources must be secured through the public coffer to ensure sustainability and to ensure universal coverage. We cannot address issues of eye health care as programs or isolated projects. It has to be systematized. The initiative by its very nature is multi-sectoral and therefore must be adequately coordinated, and there must be strong leadership of the prevention of blindness as a national development imperative. And then finally, the final building block of your system is that it must be grounded in a multi-sectoral integrated information management system that generates and secures the analysis and critically the use of data across all of the sectors to plan, monitor, report on progress against the common goal. So when we are talking about our treaty and our development instruments, we are not just talking about the adoption of policies. When we are talking about advocacy, it's not just about advocating for stronger policies, but advocating for policies that are then systematized to secure universal, sustained quality health coverage. And this is exactly what is then prescribed by the treaty and development instruments that all of our African countries have committed to. And this presents an invaluable legally grounded advocacy opportunity. It presents us with an opportunity to advocate based on these commitments for strengthening the building blocks so in a way that they will comply with the requirements as specified in the instruments, to ensure to achieve integrated universal eye health care. So the IAPB multi-sectoral systems review process has been designed to support the leveraging of this opportunity for effective advocacy for universal eye health care. It is a tool that is presented in the form of a facilitated process for collecting information for the development of effective, smart system strengthening advocacy strategies by partners across the African continent. It is designed and provides a diagnostic framework based on the global and regional commitments that have made. It facilitates a process of data collection to measure compliance against the requirements as specified in these instruments. Organs across the health system building blocks that I've just shared with you, to identify strengths and gaps in existing responses at a country level, to inform the development of an advocacy strategy to strengthen the system to comply with treaty and development obligations. So the multi-sectoral systems review supports a rights-based assessment for developing a smart advocacy strategy. So it is a process and tool to guide advocacy. At the same time, it's an advocacy tool in itself And I say this because it is grounded in a set of questions that are aligned to the legally prescribed system strengthening requirements that have been set up in these instruments for all sectors. So by virtue of the tool itself starts becoming a mechanism for raising awareness of what those prescribed responsibilities are. The process of collecting data and completing the tool requires all role players to actually reflect on what those requirements are, and often those requirements are not known collectively across the different role players. It is a tool that is designed to be completed by your multidisciplinary in-country team, drawn from representatives from all of the sectors, not just the health sector, to engage in a process of self-assessment of compliance against each of the system's building blocks, to identify the gaps, and then based on those findings, develop legally grounded asks that are very specific to the specific systemic building blocks that are within the purview to make the changes that we want to see made. So what then is the objective of the process? The objective of the process is to support national role players, develop smart system strengthening advocacy strategies for advancing the realization of universal health coverage for the prevention of blindness and vision impairment. It is made up of 3 steps which are interrelated. The first of these being the Multi-Sectoral Systems Diagnostic, which is a tool that is designed to identify strengths and gaps in the existing systemic building blocks in country. To then follow the process of analysis of data that has been collected to compile a diagnostic report and recommendations, identifying those systemic weaknesses. And on the basis of the very targeted gaps, develop an advocacy strategy to strengthen systems with specific target strengths which are grounded in law. So we had the pleasure of piloting multi-sectoral systems review process in Kenya in 2021, and I'm going to share with you the key findings of that collective multi-sectoral initiative in a very snapshot way. And I apologize to the Kenyan team, who I'm sure are on this call today, for the brevity of the summary, the highly summarized form of some of the findings. But what we see here on the left is we see the 6 building blocks of the health system that are required. And on the right-hand side, we'll see that the responses have been coded. Now, the objective ultimately is to secure universal health coverage. Every one of those blocks has to be green, currently either amber or they are dark red, meaning that there is still quite a lot of work to do in relation to the implementation measures that have been prescribed by the treaty and development instruments. So we know that the most important catalytic systemic building block that has to be in place is effective coordination of this multi-sectoral initiative, and that this needs to be and this is indeed prescribed by the treaty and development instruments, and what the coordination, pardon me, what the coordination arrangements look like are prescribed. So based on the requirements, the Kenyan team looked at what was currently in place in Kenya as measured against those requirements, and identified that there are many coordination structures in that are relevant to or have an impact on coordinated or integrated planning that impacts on the prevention of blindness. But the mandates and the relationships of these different structures with each other and with regards to the national goals around the prevention of avoidable blindness are not clear. We see gaps in representation on these structures, gaps in participation, and lack of clarity in terms of mandates and the roles and responsibilities of the different structures. And critically, what we see is that coordination is very people-led. And we must remember that coordination is actually achieved through alignment and integration of systems rather than just people. Systems are coordinated, or systems coordinate responses. And what we see is that because of these gaps in terms of mandate, representation, and participation, the microsystems of the differences are not attached to the national goals. We do not see good coordination and integration. This then really is the bottom or the basis for many of the other gaps that we see. So there are a number of requirements in terms of policies and laws that are required. Critically, one of the most sort of important and catalytic requirements is that there is one national eye health strategy, which is multi-sectoral in nature, identifies the country's shared national goals around vision to ensure that there is aligned statewide planning across these different sectors to advance that shared common goal. So when the Kenyan team looked at the policies, plans, and strategies across not just health, but the other sectors in Kenya, we found that there were many sector-specific policies, plans, and strategies, and that these were particularly strong in the health sector. The other sectors were rather weak in terms of existing policies, plans, and strategies. But even within the health sector, inadequate coordination and alignment resulted in a fragmented, clinically focused set of services. And what was lacking was having one integrated national eye care policy and supporting plan, which brings together all the sectors to achieve the shared goal. This then moved on to the question of, well, then what programs are in place? So Kenya does have a national eye health strategic plan. However, it is very clinically focused, very health focused. It is not adequately multi-sectoral and integrated, and critically, it doesn't define the prescribed multi-sectoral package of services across not just health, but the other sectors that are required to ensure universal healthcare, as was so well defined in that very first presentation. To this, that in order to meet all of the other systemic requirements, you need to have a very clear policy and a very clear statement of the package of services that are required based on the scale and scope of coverage that is required. Because, I mean, without that, how on earth are you going to decide what human resources are necessary, what infrastructure and what financial resources are necessary, and then set out to plan that? So it was therefore not surprising that in the absence of this national policy and a comprehensive eye health strategic plan, human resources gaps are significant across all sectors. There is a draft human resources for eye health strategy. However, it focuses on clinical or professional gaps in the health sector, rather than on the eye health human resources required across the full continuum of sectors. And even within the health sector, the focus, as I said, was very much on curative clinical services. So that human resources for eye health strategy is a strength, but it does need to be strengthened. And that strengthening in turn depends on strengthening the sort of outer layers of this enabling environment. Infrastructure is very similar to the issue of human resources for eye health. Because there isn't a national integrated multi-sectoral plan, policy and implementation plan, it's very difficult to understand what constitutes adequate infrastructure to plan for it. So what we see are large infrastructure gaps in the sectors, not just health, but your other sectors. The biggest gap underpinning all of these is the lack of financial resources. So without a clear integrated policy and plan, you cannot develop a costing, and the costing and resource mobilization that is necessary becomes difficult. If you do not know what you're needing to raise resources for and to sustain those resources, it's almost impossible to engage in advocacy for increased allocation of resources. So too, you need to have evidence as to the returns that will be achieved on the investments that you are asking for. So one of the key requirements is to have an investment case for the requested additional resources, and that too is lacking at the moment. So what we see are very, very limited funds, and programs are currently heavily reliant on donor funding, and this impacts scale, quality, and sustainability. And then at the heart of all of this is the absence of a multi-sectoral monitoring, evaluation, and quality improvement framework, which is aligned to that policy that was missing. And as a result, data is not routinely collected, analyzed, and used by all sectors other than the health sector. So the health sector does collect data. However, it is limited by the limitations in the enabling framework. So as you can see through this process of the very structured analysis of the landscape in Kenya, we were able as a team to start identifying where the critical and catalytic gaps were, and are now ready to move to that point where we can start framing very clear, very well targeted, very specific or smart advocacy requests to strengthen the system, which is the essential building block that needs to be in place if we are to move towards achieving improved realization of universal health coverage in Kenya. So thank you for your time. I hope that I did the Kenyan team justice in pulling together a very complicated process into one slide of findings, but thank you for your time.
Patricia, thank you for your presentation. I was part of that exercise.
Simon, can I hand back to you?
Yes, indeed, Patricia. Thank you for your presentation. I was part of that exercise in Kenya, and indeed, when we met after the pilot, the Kenya team found it a very rich and worthwhile experience. And one of the key things that came out of it was how.
Sorry, is Simon still there? I'm just not sure. Have we lost Simon?
I believe I'm here.
Yes,
Russell,
we can.
You let me know? You can hear
Yeah,
me?
I can hear you, Simon. Yeah, you're fine.
Super. Thank you. So I was just saying how I was part of that team, and the Kenyans found it a particularly worthwhile experience. So thank you. I'm just aware of time right now, and I have two mentions to make. One, if anybody's interested in the tool that Patricia has just presented, please do contact me at IPB, and I can discuss that further with you, and I can even share the draft of the tool, not the Kenyan review, but the basic tool itself. Unfortunately, we can't go into any further depth just at this point because of time. Thank you. I will be wrapping up now. I'd like to thank our audience. I'd like to again thank our sponsors who allowed us to bring this to you. That's CBM, the Lions Club International Foundation, Novartis, Roche, the Saver Foundation, OneSight, Operation Eyesight Universal. Our thanks to you, both for allowing us to bring this to you, but also for participating in these events as well, and bringing your rich knowledge and experience to our audience. Thank you, Russell. Next slide. So briefly, I'd like to tell you about our Love Your Eyes campaign. In 2021, the IPB board asked us, they set up a task to come up with a global campaign that would have one overarching approach, one voice, one campaign. And what was great was that we already had a campaign, our globally successful World Sight Day theme from last year, Love Your Eyes. We decided to focus on 3 actions to bring our campaign to life and be strong with rallying calls to action. Next slide, please, Russell. So we came up with the 3 Love Your Eyes actions. Next slide, Russell. And these are accessible eye care, available sight tests, and affordable glasses. These are 3 actions to educate, inform, and encourage. And each means something different, but they're all part of the same family. By accessible eye care, we mean access to treatment and surgery for the vast array of eye health issues, including cataract, trachoma, glaucoma, diabetic retinopathy, and many more. By available sight tests, we mean that no matter who you are, where you are in the world, in a school building, in the workplace, in old age, you can get the sight test and treatment you need and ensure you are looking after your eye health. And finally, affordable glasses. Important because the vast growing numbers around the world that need a pair of glasses or lenses but cannot access them because of costs and regulation barriers that need to be broken down, and also because this because it is the experience that the most understandable and or relatable to the public. Next slide, please, Russell. So what we want accessible, available, affordable eye care for everyone, everywhere. Also, next slide, please, Russell. We'd like to tell you about World Sight Day. World Sight Day is just around the corner, and this is a reminder that World Sight Day is our biggest opportunity to shine the light on eye health as an economic, educational, and development issue. This year, we're focusing on the decision makers around the world, and we invite you to get involved in any way you can. Please visit our website to jump onto the biggest advocacy campaign happening in the sector in 2022. I am going to wrap up now. I thank everybody again. I thank our presenters. I thank our panelists. I thank the knowledge team from IEPB who've put in an immense amount of work to bring this to us. And I thank you, the audience, for taking your time on a Friday afternoon when most of you, I think this time is your own. We are enormously grateful. We hope we've made this worth your while. Please do check it out on the IEPB website. If you found this helpful, share it with your colleagues. We will be making this video available via the website. Thanks again to our sponsors, and I bid you farewell and a good upcoming weekend. That's it from me. Thank you. Bye-bye.